All right. So MRCEM OSCE. The exam format is very practical. It is an objectively structured clinical exam. You've got 16 stations, and the time is roughly about 2 hours and 42 minutes. So you've got 16 stations and then two rest stations. The stations are 8 minutes each, and 1 minute is outside the station that you have to read and then make up this quick mind map of how you're going to proceed. Okay. All right. Location wise, the exam is held in London, Malaysia, and then a few parts of India. What they are testing in this exam is your communication skills and your clinical skills and how you deal with the applied knowledge with both. The pricing of the exam, if you are an RChem member, is about $566 as of 2025. And if you're not a member, it's about $659. Now, these are 2025 prices, and they have started increasing them every year. So depending upon which year you give the exams, this is roughly how much you should have saved up if you're preparing for the exam in London. For Malaysia and India, the charges increase. So for a member in Malaysia, it's about £1,063. And for a member in India, it's about £918. So it depends really where you want to give the exam, or more likely where you end up getting a seat in the exam. Also keep in mind that you do have to keep this number in your mind because you are going to be saving up for the exam. So you should know what price range you're looking at. So the dates to watch out for. So the Malaysia date is coming up in September, and the application window has already closed. And I wanted to do the webinar now because many of you might have applied for this exam. And so you need to have a basic idea of what's coming or what you are expected to know for this exam. And then you've got the Indian date that is going to be in July. All right, so the application process is fairly simple. If you've done your MRChem primary and SBA, you don't need much. You already might have your license to practice, your house job certificate, and a primary medical qualification that's compatible with the GMC. You should have 6 months experience in emergency medicine other than house job to be able to apply. So once your experience is adequate, they'll be allowing you to appear in the OSCE exam. They have also added a 2-year stipulation for the MRChem SBA. So if you have to fulfill that as well. So 2 years of experience post-house job for SBA parents, and then plus 6 months exclusively in emergency medicine. So limited seats are available. So most of the time you end up in the oversubscription criteria. And what happens is the oversubscription criteria is very annoying, honestly. And what happens is that we end up waiting for the exam for a really long time. I have to wait for about a year. And I applied like 4 times and I got the seat in the oversubscription criteria in the last attempt that I applied for. And I appeared in London. Right. So yes, preference is given to UK trainees. And then it's doctors working in the UK that are not trainees, and then Ireland, and then you end up having a seat for all the others. And this is a random allocation, so it's not going to be first come, first serve. All right, so you've got a seat. Now what? What are your plans? So once you have a seat, usually it's going to be on the oversubscription criteria, yes? What happens is when you get a seat on the oversubscription criteria, you literally have about 45 to 50 days, okay? And 45 to 50 days is not enough to start practice from scratch, right? So you have just this amount of time to plan your trip, get your finances in order, get the visa process sorted, figure out where you're going to stay, how long you're going to stay, what flights you're going to take, are they going to be connecting? So all of these technical stuff is what your time is consumed by. And you also, considering that you might be working, You also have to take into account that you might have other responsibilities and you have to figure out how you're going to work around those. If you've got kids, you have to figure out, are you leaving them? Are you taking them? Is it financially beneficial for me to take them or leave them? So you have all these important decisions to make, especially if you're coming from a foreign country. If you're already in the UK or the island, it's really fairly simple. But if you're outside of these regions, it's going to be a bit difficult for you to figure out your travel plans. My advice would be that you start this process the minute you apply for the seat. So for example, it is now currently 14th of June. If you've applied for the September diet, you know that you're going to get a seat in Malaysia. Look at the visa process for Malaysia, how long you need, what documents you require, have them ready, plan your trip, look where you're going to stay. You don't have to make those bookings. You don't have to pay anything in advance, but just have that mental image of where you're going to stay, what are the dates, will I get a room, how many rooms do I need, and what dates am I looking at? Do I have enough finances? Do I have the seat for the plane ticket? All of these things. Just have a workaround earlier on so that you're not pressed for time. Because once you get a seat, the mentality changes. Now you're really worried about your preparation and you really have to focus and you're not going to get time off work. You can't take that much time off work. So all of these things might pile up and put you in a lot of stress. So to avoid stress, get started on with these things a lot earlier. Okay. Then, if it's a London flight, that is a very hefty process because the visa application for London or UK takes about 2 weeks. So you do have to factor in that you apply in time so you get the visa back within that 2 week period. Okay. And so that you're able to fly. So be ready with all of these things. The UK visa application form is really long. So my advice would be to start filling it up. That you can save the application for up to 6 months. So easy to fill. Once you get the seat, or not get the seat, I would say once you apply for the seat, start filling up that visa application form. It's really long, it's really tedious, and you should be able to get done with it, get these kind of formalities out of the way so that you are able to focus on your preparation and are not distracted by these menial things. If that helps. Okay. Then let's look at the timeline. So now timeline depends on where you started from, basically your baseline. NHS exposure. So if you have worked in the NHS or you're in a workplace that speaks in English, okay, then you don't need a lot of practice, I would say. What you need is just fine tuning. So 2 to 3 months of learning the NHS system should be enough. Okay. However, if you've never worked in the NHS system and your workplace does not require you to speak in English, then you are looking at a longer time. So I would suggest 6 months. Now, these 6 months can be before you apply for the exam, ideally, or you can do like a 3 month thing. So 3 months before the exam, you start preparing, apply for the exam, hoping for the best, you get the seat. And then by luck, you end up getting a seat on oversubscription criteria. And then you work really, really hard in the next 45 to 50 days. And there's a chance of something. So roughly 3 to 6 months is your timeline, but you can clear this exam in less. When it came to my timeline, I did not get a seat. So I was preparing, but I wasn't getting a seat. So I was a bit disheartened by the end of like my third attempt. And I would like go in and out of like serious practice, leave practice, serious practice, leave practice. That was how it was. Whenever I would apply for the exam, I would get a bit serious. And then when I wouldn't get the seat, I would just leave everything and be like, okay, fine, next time. So that was what happened. But when I was trying for the last attempt, I wasn't really expecting to get a seat. So I was basing it on my previous experience of me practicing. And I had gone through the syllabus once. It did not take me long. And I did not take any courses at all. And I still was able to pass only on the basis because I had the NHS experience. And I was almost studying or practicing for this exam for about 6 or 7 months already. Okay, let's look at the preparation. So spend time looking into how you revise best, because this exam is really tiring, especially because you're waiting for the seat. And because you're waiting for the seat for that long, it tires you out because you study so hard, you hope for a very good outcome by getting a seat, and then you don't get a seat. And so you kind of give up. And you have done the syllabus, you have covered everything, but you're still not there yet because you're hoping that when you get the seat, you will get there. Okay. So what happens is you end up not wanting to go through the big books because you've already covered them once. So make notes, make little notes, make cheat sheets, things like that, so that you don't have to go over the big stuff again. Okay. Learn how you revise best. Now, what that means is, do you revise best in a group? Do you revise best alone, talking in front of a mirror or recording yourself and then listening to the recording? However works best for you is your best bet. And now coming to the notes, your notes, the ones you make by yourselves, are going to be the best option. And I say this because you know what you've written, why you've written, and it makes sense to you. Not every kind of notes available online or free resources are going to be your bread and butter. You might have to take something from one note. You might have to take something from one guideline and then make a pattern or an approach or a structure for a specific station for yourself and see how you do with that. I would also recommend having some phrases. Okay. So have a very strong introduction. Now you have 16 stations, right? You don't need to change your introduction because in every station, there is a separate examiner, there's a separate simulator, and you can use the same phrase in all 16 stations. So have a very strong introduction. For example, you can have something like, hello, my name is Dr. Shaya. I'm one of the ED registrars. And if it is a talking to a patient kind of station, you can say, how can I help today? If it's a recess station or trauma station, you can just say, I'll be leading this pre-alert. Can I just confirm your names? So have this really strong introduction and then work on it, okay? Because that initial 30 seconds are your best. If you do the initial 30 seconds best, the examiner is expecting a good result because he thinks that you are confident enough that even after like 10, 12 stations, you haven't given up or tired yourself out, even though you will be tired, really tired. But a strong introduction helps you. Okay. So practice that, keep it same for every station, and no one will know. And you will end up scoring high. So make sure that your introduction, whatever it is the best you've got. The other thing would be buddy up with colleagues. Now, this is really important because this is a practical exam. You need to practice. You can practice in front of a mirror, but you're not going to be able to know your mistakes. And someone else, a third person, will be able to better know your mistakes. Now, there are two ways you can do this. You can actually have people over and you can practice with them at the hospital, at home, in person, or you can record yourself in front of the mirror, practice with somebody and make a video or an audio and send it to a friend and get them to give you an honest opinion. Or you can just practice online with people, which is a very easy and simple way. All of these methods are really brilliant, but you need to know who you are asking the advice from. And this is important. Okay, so somebody who themselves is not confident in picking out their mistakes or doesn't know what the exam structure is or how they're marked or what they're looking for, what happens is that they will not tell you what's wrong in your practice. And you will be continuing to make those mistakes. And once you've started practicing in that way, what happens is by the time your exam comes around, you have really solidified those mistakes. And now you confidently make them in the exam and end up scoring really low. This is a competitive exam. Please keep in mind. The passing score will change every single day, depending upon how the candidates do. And if you end up giving the exam in a London diet, you are competing with UK graduates, you are competing with UK trainees, okay? And they have been training in the system for the whole of their lives. They have been training in that system for quite a while and they know their stuff and they're going to score high. So the passing mark is going to go higher up as compared to the other diets, okay? And you're going to have challenges with the accent. You're going to have people who are natively British that are simulators as well. They're not going to have a different accent. They are going to be British. So you have to figure out how to understand the accent and then do the station and do it to the mark that you are able to compete with UK graduates and trainees. So you do have to know what mistakes you're making and you don't make them and you don't solidify those mistakes to a point that you do them as a second nature and not realize that you're making those mistakes. I have worked with many candidates who end up making very little mistakes that can actually cost you communication marks because all you're doing is addressing them the wrong way. You're calling them Mr. When it's a doctor, you're calling he, a she, and she, a he. These are really silly mistakes that you don't expect anybody to be making. But when it comes to the exam stress, sometimes you kind of not even realize that you're using these phrases and sentences really wrong. And somebody else might be able to give you that advice. So please choose your practicing partner really carefully and prefer somebody who's going to be honest with you, is not afraid of like hurting your feelings. I'd rather have somebody hurt my feelings and teach me the right way before the exam than me going into the exam, making a complete fool of myself, wasting a lot of resources, a lot of time, and a lot of money, and ending up with like a bad outcome. Okay. Use the experiences of your examiners in your hospital. So you can use this. If you're lucky enough to work in a hospital that has an MRCEM consultant or registrar there, use them. They'll be able to help you out and they'll be really good partners to practice with, honestly. If you don't have somebody, then find online somebody who's online and can actually work with you with the hours that are suitable for you and be able to practice. So like I said, a lot of marks can be obtained from a good opening and closure. And you must have a standard pattern for this. So close, good practice, all 16 stations, learn how you're going to open a station and how you're going to close a station and use that for all 16 stations. And do this like you would just introduce yourself in your hospital every day. Learn this by heart as a second nature. Lastly, for preparation, practice, practice, practice. I cannot stress this enough. That's why it's in bold, that please practice as much as you can, even if you know everything. Even if you feel like you're the best EM consultant there is, for OSCE structured exams, any of them, you do need practice. And you need a lot of it. Okay. Sorry. All right. The second thing is timekeeping, because even if you know everything and are not able to say that within the time that's allotted to you, you will lose critical marks. So timekeeping is also very important. Make sure you always have a timer with you. Don't practice like saying, okay, let me practice for this. Initially, we will practice without the time. I made that mistake. I initially thought, you know what? Let me complete the station. I will practice with the time. Let's ignore the time for a while. We will do that when we're better prepared for it. I would now, in hindsight, think that I would have advised myself against it. And so for the upcoming candidates, when I practice with them, I say always have the timer on. You need that time, you need that ticking time on your head to be able to perform so that you at least feel 10% of that exam pressure and are able to realize how good you perform within those exam circumstances. Okay. So resources. Now, what resources I had? Initially, when I started thinking about OSCE, the first book I referred to was the FRChem 125 OSCE Stations, and I did complete it cover to cover. The only disadvantage of this book is it's really boring. Okay. And the guidelines are outdated, some of them, not all of it. It's a brilliant book, mind you, but the guidelines are outdated. And it is, I found it really boring and I could not do it on my own. So I had a brilliant group of friends and we would study cover to cover every day. And we finished this book in about 2 months, I would say. We would practice daily. So we would do one station daily and like try and cover this. We tried really hard and we got through it in 2 months. The OSCE revision for the FRChem final, that is also a book that you can use. I personally did not use it, but I do use it as a reference book now to teach the OSCE course. There are Bromley videos. That's a very minimal amount of subscription. I think it's about £29.95 when I was giving the exam. And I did use these videos. So I did subscribe for this for 1 month, saw all the videos and then unsubscribe. So you can use that as well. There are many resources on YouTube that are absolutely free for you to watch. And I would recommend you to watch this. The best way I was revising or actually getting into that OSCE mindset was with these YouTube videos. And I would watch them on my way to work and back. That was the best time for like watching these YouTube videos. I would put my headphones in and I would watch these videos to save time because I was working full time and I had responsibilities at home. So I did not have that much time to practice and be able to get things done effectively. That is my advice on how to utilize your time if you feel like you're really busy. The other thing that is crucial for the exam is going to be your NICE guidelines and your research guidelines. They have been updated, many of them. Please refer to the NICE guidelines and the research guidelines for any management plans. Patient.info and Geeky Medics. Now, Geeky Medics videos, they are free ones. I did not subscribe to the paid version. The free ones were good enough. There are written resources on Geeky Medics as well that you can see, really good ones for examination. Patient.info is another really good website. And this one, I used it for explanation. So how do I explain diagnosis to the patient? How do I explain pneumonia? How do I explain sepsis? How do I explain knee dislocation? So all of these things, how do I explain it to the patient in the patient's words without using medical jargon? Patient.info was the website that I used. So these are really good resources if you are considering giving your OSCE exam in the upcoming days or upcoming dates. You might want to have a look at all these resources. Now, the burning question that most of you ask is, should I go for a course? Is a course for me? Now, this will depend on your preparation and finances, okay? Not everybody needs a course, and I have proved it by not ever having taken a course. But I did have NHS experience. I did have people, mentors who helped me in different ways. So it really depends on you. Do you have the finances to be able to afford a course? Because most of your OSCE courses are really expensive. They cost as much as the exam itself. And do you think you have that much resources? Go ahead. If you think not, you're pressed for resources and you have to choose, then I would suggest trying other way, okay, or waiting it out because the seat is really precious, okay? You have waited really long for the OSCE seat. You don't want to put all that money in to get a seat and then not have a favorable outcome, all right? So a course is an investment and it is a very demanding investment for some of you. But it's still a viable option because you want to do this once. You don't want to do this more than once because it is a costly exam. However, there are a few options now popping up that are not as expensive. One of the options you've got in Pakistan MRCEM Academy, we do offer a course and it's not bank breaking, and it will give you that taste of a course and help you study for your exam. There are more like these. Not really sure about their credibility at the moment. I haven't seen much results, but the well-known courses that we all know about are still available. They are really expensive though. So it's entirely up to you how you want to do this. I would not recommend a course that that does not have at least somewhat British trainers in it. You choose a course that has some British trainers or somebody who's worked in the NHS at least, like Bromley's. The other courses I cannot recommend, honestly. And the reason is I've seen majority of those people fail. I'm not saying they're not teaching right. I haven't taken their course. I cannot comment on it. I just know that many of my candidates that I have worked with had trouble passing the exam while they took that course. Bromley, however, has a really high passing rate and they're really good simulators. So even if you don't take their full course, you can take their mock course, which is not that expensive, or their 2-day rapid review courses or a rapid review 1-day mock course. They are available online as well. So all of these are good viable options if you don't want to go for a full 6-week long course like ours for MRCEM Academy. Now, if your bases are good, if you've got everything sorted, practice, one-to-one practice is the best option for you. If your bases are not strong enough, I would recommend a course. Get yourself into the habit of what an OSCE demands off of you, and then you consider practicing one-on-one. Now, like I said, it is really important to practice in supervised groups where honest feedback is given. Otherwise, you will continue making mistakes, and that is not going to be beneficial. Sorry. All right. So never practice with someone you have to teach. They will set you back. Now, this is a very important advice. If you realize during a session that you end up teaching them a lot more than they are teaching you, then I'd say that's not a good person for you to practice with. Okay. You do need to practice with somebody who is either at your level or a bit better than you. That's your best option. Okay. Or you can practice with somebody who's cleared the exam. They might not have a lot of time for you because they might be busy in their life, but you can still practice with somebody who's already passed the exam. They would be a very good candidate for practicing. Now, coming to what we offer. In our OSCE course, we will be running a 6-week long haul course, and 6 weeks is a really long time. And because I want to make sure that everybody, we can cater to everybody who joins the course, we usually do take very small groups so that we can give individual care. And I'm able to understand each and every one of your weaknesses and be able to work with you on them so that you're not making the same mistakes. We do cover all the SLOs. We cover from 1 to 7, all the SLOs. However, we do hybrid stations. So you might feel like SLO 1, 3, 7, and 9 are all combined in one station, and that's because that is how the exam has now changed. All stations are hybrid. This last night, London night that we had, it had all hybrid station. Even the teaching station, they've messed them up. And I will give you a taste of what they have started to add now towards the end of the presentation. But it is worrying because they're not giving you those typical, oh, this is a history station. Oh, this is a communication station. No, you've got history, communication, recess, all in one with some counseling and safety netting and a management plan. So you've got this whole hybrid scenario that you would actually face in real life, but they have now shifted towards these kind of OSCE scenarios as compared to the simple, straightforward scenarios that were coming a few years ago. So there will be, it says 4 days. I've shifted it to 3 days of live lectures now for this course. And we've increased the days of practicing so that you get more practicing and less of the theory part so that we can get you to practice yourself. So 3 days of live lectures where we cover theory and then one-on-one practice first. And then the rest of the 4 days, you all can practice amongst yourself. So the candidates itself, we divide them into groups and they practice together. And they are able to either send them their recordings to us and we can give them feedback, or they can send a video, or if I have time, I might even step in and, give them an hour or two just to see how they're doing together and practicing. But again, practice is key. So it's not a very, you can listen and not interact and not talk. It's a very interactive session. We prefer them to interact and answer as we go along so that we're able to help them figure out where the weaknesses are. What do they lack? Is it sentence structure that they're struggling with? Is it the knowledge that they don't have, or whatever they feel is the difficult part? We do have recordings, so we do record the sessions. However, it's not a recording based course. So you're not going to be able to just not take any session and ask for recordings because the sessions are really, really interactive and I want you to practice with me and not make mistakes. So if somebody is just interested in recordings, I do have my previous course recordings available that I can consider giving them to you. And you can reach out and be like, okay, I don't want to practice with you. I don't want live lectures. My schedule does not allow it. I just want recorded ones and I can give them to you. But that is going to be a different scenario. So if somebody is into that, they're not looking to go for the exam now, they can have access to the recordings temporarily, have a listen, and see how they do. But I will not recommend this for somebody who's actually going for the exam. I do think that you need to attend the live lectures and practice because otherwise you're not learning really. Okay, so this is the OSCE blueprint. We'll be starting on the 21st of June to the 2nd of August. We are targeting Malaysia Diet. The investment you make for this course is going to be about 35,000. We are not taking a lot of people, so 15 is max because I believe that you need to work one-on-one with people to be able to get them better. The criteria for applying for this one is first-time OSCE takers and anybody who's appearing for the upcoming diet. Okay. Now there are other options. The rapid review course is something that we've introduced this season, and this is going to be starting from the 9th of August. This is not going to be a theory session. This is only going to be OSCE scenarios, practicing one-to-one, back-to-back, 2 weeks straight, all types of sessions. And this is only for people who actually have a confirmed seat. So we're not going to take anybody who does not have a seat. You will have to send us your confirmation for the seat to be able to apply for the rapid review course. And then we've got one-on-one coaching. This is also for somebody who has a seat only. You can get a mock exam and you can have per-hour sessions with me, just you in the session, and we practice stations that you want to practice. You can just let me know a day before. However, this is also important to remember that you have to book these ahead of your exam and send us an email so that we can give you some slots because a lot of candidates book a one-on-one session and I cannot, get all of you that sorted in one day. So we might have dates staggered around the exam time. So please ask if you are interested in one-on-one coaching, just ask for this a lot earlier once you have your seats and then later because we might not be able to slot you in. All right. This is just a little bit about me, who's going to be teaching you the OSCE course. I have been working at an ST3 level in NHS. I came back to Pakistan, finished my CCPEM and my MRCEM here, halfway through my DCH. I am currently the head at the trauma center at PF Hospital in Islamabad. And my goal with all of this was to get you an affordable course that does not break the bank, that does not make you think, should I need a course? Should I get a course really? Or should I pay for the exam? I don't want you to choose. I want you to get the course, get the education and the knowledge that you can have and be prepared and equipped to pass this exam in the first attempt and not waste your money or your resources or your hard-earned time that you've put into it. And I hope I'm able to achieve that. All right, so let's go on to the exam day. Now, once you have the seat, you're prepared, what are you going to do? How are you going to get to the exam? A day before your exam, please go and visit the exam station. The exam, where the exam is going to be held, okay? Make sure that you know how you're going to get there. If it's Uber, check that. If you're going to take the bus, make sure you check the timings and the weather and see if there are going to be any delays, especially if you're going for the December one. There can be snow, there can be delays. Please keep those in mind. The tube might not be working in London. You might have to travel long distances. So stay near the exam area so that you can actually get there by foot. Okay. Don't stay too far. Keep in mind that especially in the winter seasons, the tubes are down. You might have delays in the bus as well. So you have plenty of time to spare. You should get there within that time frame and are not late for the exam, especially if you've got the morning session. There are two sessions, morning and evening. So the morning ones are the hard pressed ones, I'd say. Ensure that you have your identification. So you need your passport or your driving license. You can dress up as however you want. There's no restriction. However, it has to be a bit professional. You can wear scrubs and you can also change I'm talking about the London diet. So you can change in the exam center. Ensure you've had plenty to eat and drink and had a toilet break. But don't worry, when you go in the exam center, there is a toilet that you can use before your exam. Sorry. Tips for OSCE itself. So each station will have a description of the scenario and what will be expected. The allocation of marks is displayed on the pie chart as is shown. So there will be a pie chart outside the station. Read the pie chart carefully and answer what it asks, not what you want it to ask. If you feel lost, stop. You can always ask for or say you want to look at the pie chart or you look at the exam scenario. If one station doesn't go well, try to put a line under the thumbs. Easier said than done, I am aware, but try to forget that station and focus on the next one. Not all 16 stations are going to be stellar. You are going to mess up one or two, and that's okay. That's all right. You don't fail the exam just by failing one or two stations. Time is yours to gain marks. So if you think of something else that you should have said or asked and you still have time, say it. Even if you close the station, it doesn't matter. You can still say it. You will still get marks as long as you've asked or said it. Okay. What to expect when you walk into that exam center. 16 stations, 2 rest stations. All of the candidates will be briefed together in one room. Candidates are placed outside their first station. So you will be standing in front of whatever number is on your card. You will be handed a card, and on that card is a number. That's the station you'll be standing outside of. A bell will ring, informing you for the start of your reading time. So once the bell rings, you can start reading the station. Another bell will ring, which will signal the start of your station. So you walk in. Depending on the scenario, the examiner may ask you to present your findings or say nothing, with the ending of the station being signaled by another bell. What that means is when you walk in, the examiner is going to stay silent. There's only 1 or 2 stations where the examiner might ask you for your findings. Otherwise, the examiner is just a fly on the wall. They will not interact with you at all. You will then be directed onto each further station until the exam is complete. In the rest stations, you will be offered some water. You will be able to use the toilet during that time, or some candies or mints that are there in the station. These are the SLOs that they expect you to know. But because they're giving you hybrid stations, so this is just a mix of everything that's going to come in the exam. But this is generally what the scenarios are like. Hybrid stations model. So this is what I had in my exam. I had 3 stations from SLO1 overlapping with communication, 2 stations from SLO2, 2 from 3, 2 from 4 as well, 1 PEDS SLO5, 2 from 6, 7, and 9. So teaching, the procedures, all of these. The marking scheme, well, this is a very busy slide, but let me just tell you that they do test 4 domains: clinical reasoning, communication skills, history taking or information gathering, and clinical examination skills. And these are all applied to almost all 16 stations. And this is how they will mark you: well below minimum level of competence to well above level of competence. And that's how it's going to be. Very poor level of knowledge and then good knowledge, frequent minor errors to no errors, task not completed or task completed to the highest standard. And your preference should be to be in this level at least for at about, sorry, for about 12 stations. You should be here or here. You should not go below this because there's a chance that you might fail. Now, common causes of failure. This is what I usually see in very commonly in people who've given the exam and are not passing. Number one is not reading the brief. They're so caught up in the station that they forget what the prompt was, what they were required to do. Okay. And they just completely go off the tangent. If the station says examination and you start taking history, you are screwed. So be careful when it comes to this. Okay. Then is poor structure. So every type of station has a structure. And if you're not following a certain structure, then you are, well, setting yourself up for failure. So make sure that you have your structures written in an order for every type of station. All 16 types of stations, write a structure, how you're going to do. If you do this, you do have this, you this, and have that structure so that you're not messing up your marks. Then is inadequate communication. Now, communication is key in all stations. Okay, how you say something is really important. How you talk to your colleagues, how you talk to your patient. It doesn't matter if it's an SLO1 station or a teaching station or a procedure station. Communication skills are going to be scored in all 16 stations. So how you talk or convey the information is going to be crucial for your stations. Missing red flags. Now, this is really important when you are doing either history, recess, procedures, or teaching even. All of them, there will be some red flags that are in the station for you to pick on. Very pertinent information that could either be hidden in your P3 Meftosa, that could be in examination. If you forget, for example, you forgot auscultation during a trauma station, and the auscultation had findings. Now you skipped that entirely, and now you don't have that information, so you've missed your red flag. Okay. Then is incomplete assessment. Incomplete assessment basically applies to your procedures and examination. So you, in your examination, you forgot gait. If it was a hip examination, you forgot, limb length, or you did not do it properly. You were not able to do all the active passive movements. You run out of time in a procedure, and all of these will lead you to scoring really low and be marked as incomplete assessment. Next is confidence issues. Now, you have to understand that the MRCEM exam is an ST4 bad day. Okay, that's what they tell you when you walk in. What they expect is a least qualified ST4 on a shift. That's not very confidence boosting, but that's what they're expecting. Okay, ST4 bad day. And if you're not confident as a registrar, if you are just second guessing yourself, not being authoritative, not being a leader, or not showing proper leadership skills, they will not give you the marks for leadership skills. And leadership skills are scored in all your research stations, all your teaching stations, and all your procedure stations. So keep in mind that leadership will always have marks, and they do expect you to be able to lead a shift. You are a registrar, you are leading all the F2s, and you are replacing the consultant at night. So you are supposed to lead a proper shift and be able to manage difficult situations while keeping a level head. Ignoring the examiner. Now, sometimes what can happen is if you are making terrible mistakes, if you're making blunders, or if you have forgotten what the scenario was like, the examiner might either interrupt and ask you to read the station again, or they might just push the exam stamp that you read outside is also inside on a piece of cardboard. They might push that cardboard towards you to get your attention to the examination stem or whatever the station stem is. Please don't ignore the examiner and continue doing what you were doing read the station again. And if you feel like you've made a mess of things, just say, can I just start again? And then introduce yourself all over again and start again. It's okay. It's entirely okay if you've messed up one station and you want to do it this way. The last one is poor time management. So even if you know everything, you kind of make a mess of things by not being aware of how much time you've taken in the station. And if you don't finish the stations, you kind of lose quite a lot of marks. So, like I said, always have a timer ready. Never ever practice without the timer. All right. These are your common pitfalls. I have seen this time and time again where people who think they've done brilliantly in the exam, they get their results and they're like, I don't understand what happened. So this is what happened, basically. You did everything right. Now, this you did not do. Communication style, conveying empathy and attentiveness through non-verbal cues. You did take a brilliant history. You managed everything in recess. You did everything in your teaching stations, but you were not empathetic. You did not congratulate a mother getting pregnant. You did not encourage the F2 who's interested in teaching. You were not sad when one of your patients had a fall yesterday. If you don't show these human emotions and are just robotic because this is an exam, I have to get this done, I have to be this. If you don't make the experience human, you will lose marks. So empathy is important. You walk out the station, you're like, I did this perfectly. I gave the management plan, I had the history, the diagnosis, I did everything else. And you score a 6 or a 7. Why? Because you lacked empathy. You did not listen to the patient or address their concerns. So this is really important. Second is medical jargon. If they don't understand you, they're not going to follow your advice. So the best thing is make them understand what you want them to understand in their language, the way they learn best. Don't use big words with patients just to show off your medical knowledge. Don't use big words with your F2s even. Okay? Or if you do, just try and explain them in a way that you would explain it to a child. Chunk and check. This applies to every station as well, except recess, I'd say. Chunk and check is breaking the information into little pieces. So in breaking bad news, if you're giving them some information, give them one sentence, check if they understand, then give them the other. In teaching, give them some information, check if they understand, then give them the next one. In answering questions, give them one piece of information, check if they understand, and then give them the other. Don't try and get as much information to them within that 8-minute time frame as possible. That's not the task. The task is to give them information they understand. You don't have to give everything in that 8 minutes. You can leave some of it and say, I can give you some pamphlets, some valuable resources that you can have a look at later on to understand. Okay? Assess understanding. This is really related to chunk and check. So you have to assess understanding. It's really important that these two go hand in hand. And then use the pauses. Now, sometimes quiet or silence in a station can kill you. Okay. You're doing a history station and then you're completely blank. You don't know what to ask us, and you go, that is going to kill your station. Okay. And sometimes pause is necessary for a station. Okay. So with both of them, have to understand where the pause is required. Now, the pause is required in your bad news station, right? In your bad news stations, you need to count to 10. Okay. Count to 10 in your head when you deliver that news. So you've just told them, I'm sorry, I have to tell you this, or I'm sorry, but Mr. Albert has died. Okay. Then you give a 10-second pause. And in your head, please count back from 10. So 10, 9, 8, 7, 6, and that's how you go. And you keep doing this for the second part of the station as well, that you use this pause for your bad news station. However, on the other end of the spectrum, when you don't want to pause, now what happens if you've gone blank? In a history station, if you've gone blank, okay, what are you going to do? Have a phrase ready. Keep a phrase in your head. Something like, how are you? Sorry, excuse me. Give me about 2 minutes, please. Thank you. Sorry about that. Okay, where was I? Yeah, pauses. So when you have a history station where you don't want to pause, my recommendation would be to have a phrase. Now, what I would do is I would sometimes be thinking in my head, and I don't want that pause to come out in the station. What I would do is I would either start summarizing, like, for example, I would say, all right, so what you've told me so far is that you've presented with this, you've had this, you did this, now you're not a smoker, you don't have any past medical condition, you haven't traveled anywhere. And I would, in my brain, be remembering what I have to say next while I'm summarizing out loud. You can do the summarization or you can think out loud in research stations. If you are stuck, you can start summarizing as well. So in a research station, if you're managing bradycardia, you can't remember for the life of you what's going on. You can start summarizing again. You can say, all right, so what we know so far is that this patient, 46-year-old, came with a heart rate of 46, he's unconscious. He has chest pain, no syncope. Okay, so it looks like he's got one of the symptoms for treatment of bradycardia. So we have to consider atropine first. Let's give them this dose. So you see, that way, you don't end up looking stupid and just standing there not saying anything while you're stuck in your head. What you're doing is you are getting adequate pauses and you're using those pauses properly and not being silent in the station. I hope that helps. All right. So we have covered a lot of stuff so far. Does anybody have any questions? And then maybe we can come to a few stations that I've got for you guys. We just got 2 stations. Sorry. Okay. Were you able to understand me so far? I hope I wasn't too fast. Any questions about what we've covered? Happy with everything? No questions? Okay. Thank you, Iska. All right. So this is just a template of conflict resolution. Okay. There are a lot of communication stations that you get. This is just one of the templates. We do have a practice session in between. I've got 2 stations. So if someone wants to practice, you can raise your hands now so that I can just call on you when we get to the station. All right. So conflict resolution. This is one type of station that you can get in the exam. Conflict can come as a separate station, as a hybrid station, in anything, really. How do you approach the station? This is a quick approach or a structure to the station. Preparation prior to introduction. So what you're doing is you are ensuring department safety, reviewing notes, have a senior member of the staff, nursing staff with you for documentation. Now, when you have that exam briefing, when you go into the exam, they will tell you, do not say, my department is safe, I've handed over my bleep to my colleague, blah, blah, blah. No, don't say that. Do not say this out loud. This is understood. The only thing that you have to do is when you open the station, so you walk in, you open the door. Sometimes what happens is the simulator standing or sitting usually says hello. And so now you have to say hello and introduce yourself, right? But you haven't reviewed the notes or have a nurse with you. You have to say those things and you have to review the notes. So what I like to do is when I open the door, I just say, hello, I'm Dr. Shayar. Is it okay if I just review the notes first, please, and then I can get back to you? Because obviously they are going to say hello and you can't just ignore them. So then it's a really small room and you are sitting literally in front of the simulator. You get the notes. Sorry. You get the notes and you read them. In any station where you have to read the notes, please read them properly. Don't just skim through them because of the stress of the exam or just hurry through. The reason I'm telling you this is because once the station starts, it will not look very professional if you go back to looking at the notes because you're literally sitting opposite the simulator and it's not nice if you look down at the cards they provided you, especially in Breaking Bad News. In my exam, I had to read the notes for a Breaking Bad News station in front of the simulator. And again, I did the same thing. So I told him, excuse me, can I just read the notes and then get back to you? Is that okay? And then I read the notes and I did forget the notes in the middle. And now the patient or the relative was asking me something and I was tempted to look down at the notes, but don't do that. Okay. And I didn't look at the notes. I tried to answer that question as best as I could. And in hindsight, I thought I messed that station up a little bit. But once the results came back, they did give me highest marks in that one. So I'm happy for that. But just keep in mind, don't look down at the notes, especially when you're talking to somebody. Okay. Then you have introduction. So again, have a strong introduction, your name, level, patient identity, confirm who they're the relative of, sorry, offer comfort or analgesia. This is really important. Now, my rule of thumb is in any station, after every step, I like adding an empathy phrase so that you're not forgetting your communication skills marks. So after introduction, offering comfort and analgesia is your empathy here. When you acknowledge the mistake or a problem, oh, I'm sorry this happened, or you offer them a seat, or how can I help? And when they tell you after that first open question, they tell you, oh, this happened, then add an empathy phrase here, listen and apologize, allow them to talk as much as they want to. They cannot talk for more than a minute or so. Let them talk. Apologize again, summarize what they've said. Maybe you've missed something. Let them add on a few things and then apologize for the whole situation again. Have a plan in place. Now, when you come to the plan, again, add an empathy phrase, have a plan in place, offer to see the patient yourself, offer an explanation of what happened. Now, if it is your mistake, please don't justify it. If it is a mistake, acknowledge the mistake, please. Now, you should know how to escalate. So if it's an incident that needs reporting, you have to mention, I will report this incident. I will talk to the senior or the matron or my consultant, whoever needs to be informed. And if there is some teaching required for the department, offer that. And then in the closing, again, stay concern addressed. If I wasn't able to address your concerns properly or you feel like you want to still complain, we have the PALS services. They can help you with anything you want and then thank the patient. This is your basic structure. And this is how it would usually go. Okay, sorry. So this is roughly how it would play out. So hello, my name is Dr. Shaya. I'm one of the senior doctors working in the department today. Can I just confirm your name in relation to the patient, please? I understand you have concerns you would like to discuss. Before we start, please have a seat. Is there anything I can get you? Do you need any pain relief or a drink? It's going to be situational. Okay. Then tell me, what can I help you with? I'm so sorry to hear that you had this experience. Where is the patient now? So if it is a patient, make sure that you know they're safe. Patient safety is important. How are they doing? And then whatever they tell you about the situation that they're in, you just say, thank you for informing me. Let me just summarize what you've said, and I would ensure you that we understand we take these complaints really seriously. Apologize again. You can, so these stations tend to require a lot of apologies. So find different ways of apologizing. Okay. Don't just use I'm sorry all the time. You can have some sentences for apologies written down with you, some sad sentences that you would say for condolences. When we do the session in the long course, I do make you go through all of these um, like scenarios where you would be tempted to use different sentences or phrases for different situations. And we do have a collective catalog for these that we go over. Plan again, if it's an angry patient, you listen to them. If it's a relative, you can say, I would like to examine the patient myself. And then reassure you that we take these concerns really seriously. I will complete an incident form, ensure my consultant is aware, and then you have a proper plan in place. Closure. For the time being, are you happy with the plan? Is there anything else you want to discuss? If now or later you want to raise this further, you can contact the patient advisory liaison services, and they can give you advice about how to make a formal complaint. Now, they can sometimes ask you, can I have the name of the doctor? Can I just know who to complain? So you don't know the name of the doctor. You don't know who saw the patient. So you don't have to lie or make stuff up in these stations, please. Because you don't know, be honest, I don't know the name of the doctor. I don't know who saw you. However, the health services job is to figure this out. So they can help you. They can give you the GMC number of that doctor. They can give you the name, whatever information you need. Okay? Any questions? And if there's anybody who wants to practice, please raise your hand so that we can do a quick session. Anybody interested in practicing? I have how many people here? So we've got 18 people in the session. And I'm assuming some of you might have applied for the exam. So what do you think? No volunteers?
Assalamu alaikum, Dr. Tajur. I can practice.
Okay, sure.
Let me just join in from the other side. Actually, this is my mobile phone, so I'm just joining in from the laptop.
Okay.
Okay, so I can start in a minute.
Yeah, you can read the station. You have 1 minute, and then you can start whenever you're ready.
So I'm starting. Hello, I am Dr. Rana, one of the ED registrars. May I confirm your name and age, please?
Hi, I'm Mark. I'm father of John.
Okay. So what brought you here? Nice to meet you, John.
Well, I got a call from the hospital saying that they missed a fracture in an X-ray that my son had 2 weeks ago.
Oh, okay. So, Mark, can I just confirm that how's your son feeling right now?
He's at school at the moment. He's been having a bit of pain, but that's about it. Yeah.
Mm-hmm. I'm really sorry, but is he pain-free currently since he joined school when he visited
No,
the
he's still in a lot of pain.
Oh, I'm really sorry. And for that, I would request you that you can bring him anytime to the emergency department for the pain relief as well. Regarding your concern, so when did you receive the call from the hospital?
Well, I got a call this afternoon. They said that they were worried about John because there's a fracture that the consultant had a look at the X-ray. They found a fracture and they wanted to talk to me and make sure that John's okay. But I don't understand. How could you miss a fracture?
Oh, I'm really sorry, Mark, for this thing that the fracture was missed at the moment when your son visited the emergency department. But may I confirm that on which side was the injury? Was it the right upper limb or the left?
It
Was
was
it
the
right
right
side?
one.
Right side. Okay. And how did it happen? A little bit can I get to know because I wasn't there at that time when you visited the emergency department.
Well, he had a fall.
Mm-hmm. And
And my wife was with him, so my wife brought him to the hospital to get
okay,
him checked out. Yeah.
okay. And what was the mechanism of the injury? How did it
Well,
happen?
he was running around in the house and then he tripped over the carpet or something and then landed on his elbow.
Okay, okay. And then immediately he was brought to the hospital.
Sorry?
Immediately he was brought to the hospital.
Yeah, yeah. My wife took him immediately after the fall because he was in a lot of pain.
Mm-hmm. Okay, Mark. So let me review the notes as so far that what you have received from the hospital. So according to the X-ray that I have just reviewed, John, your son, was seen by an so according to the X-ray that has been reviewed, there's just a hairline fracture onto the distal the bone of the arm. It's just a hairline fracture, and this is the reason why that your son has been complaining of pain. Are you with me, Mark?
I am, but I understand that there's a fracture. I don't care if it's hairline or
Mm-hmm.
I don't know,
Mm-hmm.
less hairline or more hairline. I don't care what hairline means. I'm
Mm-hmm.
just worried that a fracture means a broken bone, right? You
Mm-hmm.
missed a broken bone. I don't understand how that was possible. I bring my son to the hospital, and you are supposed to be doctors. You're supposed to know this shit. How is it that you're not able to pick up a fracture that my son's been running around with for a week now? This is
Yes.
insane.
I completely understand your point, and I apologize from my side and from my team side. And I appreciate your concern regarding this and regarding your son. But as far as the condition of the bone of the mark is concerned, there's not a complete fracture of the bone. It's just a minor fracture. And yes, you are definitely right that it should have had been picked up when you just landed in the emergency department. You are absolutely right. And you can even register a complaint for that. And there are certain pathways for that I will be guiding you through. But as far as your son is concerned, he is our priority. So right now, as far as his condition is concerned, there's not a clear-cut fracture. There's a minor fracture for which I request to the hospital. Regarding the missing out on the fracture when the patient was brought to the ER, I can refer you to the pathway to register a complaint. It should not happen. You are completely right. And yes, what happens is, let me just tell you that usually when the x-rays are done, they are then reviewed by the consultant radiologist who are experts in reading the x-rays. So that is why then the hospital contacts if there's any finding in the x-rays. Is that okay with you?
Yeah, it still does not explain. The consultant sees the X-ray a week later. Why can't they see it the same day so that they don't miss these fractures? And the doctor who saw my son, how
Mhm.
come he doesn't know how to read an X-ray?
So,
Why
so
is he
at
working in the emergency department anyway then?
I completely understand your point, and there are some junior doctors, and there are some senior doctors. The junior doctors are then in their learning at that time, but obviously the person who is expert in reading out the X-rays is expert due to some of the speciality, right? Because if the doctors can miss out on, and I do understand it should not have had missed out. Can I ask you that when the patient was discharged, were you recommended when to land back to the emergency department in case of any sort of an emergency? Was there any sort of advice done at the moment of the
I'm
discharge?
not sure. Maybe my wife knows. I haven't had a discussion with the wife yet.
Mm-hmm.
But I'm just still, I don't understand. A junior doctor saw my son.
Mm-hmm.
Why didn't the senior doctor see my son then? If the junior doctor is not competent enough to read an X-ray, why are they seeing patients and missing fractures? Why are they in that department anyway?
Mm-hmm.
Why was
Mm-hmm.
the senior doctor not able to like review his cases or something? I just this is blowing my mind that you're letting a kid leave the hospital with a fracture.
Mm-hmm. I completely understand your concern, and I will definitely raise this concern that the senior doctor should have had uh picked it up or not let the patient discharge. You are completely right in your stance, Mark. But for me, right now, your son and his condition is of much more priority. And I would just suggest you to bring him back to the hospital and we can then definitely deal with him accordingly. Any other questions? Any other concern from your side?
No, no, not really. What happens now? So I bring him back. I wait
Mhm.
3 hours again, like my wife had to do, and I'm frankly not really in the mood to wait in the ER again when you're just gonna manhandle my son again. That does not make sense to me.
Mhm. For that, I would suggest you to bring him back to the emergency department. Once you land into the emergency department, you can inform regarding the case in the triage, and we can have a look at the mark on a priority basis as well. Because we have already received that we are done with the case, we need to just examine him again and advise him accordingly.
Time
Later,
is up.
okay.
Okay, good attempt. How do you think you did?
Since I was just one thing was honest, I couldn't review the notes. That was one thing I just wrote it down when I started the mission.
Hmm.
I missed out on that. Uh, like I want to review the notes.
Yeah.
This one was love. Yes,
What do the
yeah.
rest of the things? What's the crowd thinking? So let's hear it from everybody else in the comments. What do you think, guys? I think this is a buckle fracture and the management will not be changed. Okay, Yaska has a comment. That is true. The management will not change. Torus fracture. Guys, this is not SBA. So I want you to tell me how did the communication feel like? So no need to bring the child in again. No, that is wrong, Yaska. So you do need to bring the child in again. The reason is the father said he's in pain. So even if you've splintered them, you have to
Oh,
make them pain free. They need to come in. And also, you don't know what happened. You were not there. Somebody else saw the patient. So remember SLO7, guys, remember whenever there's a patient that you have not seen, you cannot advise anything unless you see them. So you cannot give medical advice unless you've seen the patient. Be very careful about this. Okay. The other thing, so there are a few technical things that are wrong. Number one, do you think in the NHS you can discharge a patient as a junior doctor without your senior knowing? Is it possible?
ideally it is not.
Exactly. So ideally, it's not, which means that you just admitted to saying that your son was seen by a junior doctor not by a senior doctor. You have literally put the senior doctor's license in jeopardy. Now, tell me, is this the case that has happened in the station? Why was the fracture missed? Because it's a really hard to see fracture. It's not the F2's fault. There's a possibility that this was discussed by the consultant and the ED consultant also missed it. And the reason is it's a really difficult fracture and only somebody who looks at x-rays for a living can see it. Somebody who sees x-rays all day is your radiology consultant and they were looking at the x-ray again and they were able to pick it up. So it's the fracture's fault. You have to remember that. You have to figure out in these stations, whose fault is it? It was the fracture's fault. If the fracture is itself really difficult to see, which is why this has happened. It's not the F2's fault. It's not the consultant's fault because that is not how the system works. No patient is discharged from the emergency department without a senior review. So be aware of this. The other thing is, again, there are some, I know I have worked with Rida already, which is why I know that the empathy section has improved, but it's still lacking. There's still loads to be done. You have to, you see how worried the father is for John. Acknowledge it, appreciate him. I know you're really worried about John, so am I. Bring him back. Let us try and get to the bottom of why he's in pain and let's take his pain away. Be on his team. Use John as a common point. He's worried about John. You should be equally worried about John. Okay, make sense?
Yes.
Okay. Now, good attempt. So now the next station that I have, I really do want somebody who's, oh, so this is a key point that you have to remember for your communication station, just to review. Use your body language. Okay. Be aware of how you use your body language, especially in bad news stations. You have to be careful of how you are sitting. If you're arrogant, if you are sitting in a way, or your tone is, a bit too chirpy for a bad news station, be careful about those things. The other thing is embrace the silence. We've already discussed this. Silence is important in these stations. And in your station again, Rida, I felt like I was talking less, you were talking. So communication is a two-way thing. You say one sentence and then let me say one. Okay? Don't talk over, don't give them extra information. They've not asked for it. I asked you why this happened. Give me one line answer and see if that satisfies me. Don't use all your cards in just one paragraph and then you run out of cards. And if he asks again why this happened, you don't have any explanation. Encourage patient dialogue. So that is what I'm saying. You need to have this as a discussion or a dialogue, not a one-way communication. Involve them in the decision. So make sure that you ask him why and then come up with a shared plan as compared to you just telling them what to do. Powells is important. You need to mention that. Avoid false promises. So don't give them over the top promises. I'm going to do this. I'm going to do this. No, there's a lot of things that you cannot do. So don't promise stuff. And then stay calm. I wasn't really that angry in the station, but sometimes the simulators can be really angry. They might stand up. They're really angry about what happened, about the whole situation. So stay calm. Don't lose your cool. Okay, so these are the communication stations that you're going to get. There's a new one they've added, and that is a DNA CPR discussion or sealing of care that they've given. And recently, in the past few years, obtaining consent was added as well. The rest, you all are aware of. These are the common ones that were coming previously. So the next station, now this one, anybody can try, but I'm hoping that somebody who's already taken my course, if they want to try this, should. This is a new station they've added in the recent London Dive. And F2 has just seen a child with terminal cancer presenting to the ED with atypical pneumonia, leading to sepsis. He doesn't have an escalation of care plan in place. And the F2 wants to know how they approach the subject to the parents. Discuss with the F2 about the case. This is a mixed hybrid teaching case-based discussion kind of scenario. All right. Any volunteers, or if Rida wants to go again? I know I'm putting you on the spot, Rida. I'm really sorry about this. But this is, I don't expect you to be able to do this station anyway. It's okay. But this is a hybrid station that they've started giving in the exam. So if you want to try it, we can run it, and then I can have a quick discussion about it. Or if you don't want to try it, that's okay as well. We can skip it and just have a discussion. It's up to you. Any volunteers? Or if anyone wants to comment on the recent uh OSCE station that we did. Any volunteers?
If there's no other volunteer, then I can again practice.
It's all right. This is a difficult station, Rida, so it's okay if you don't
Okay.
get the hang of it, but take a whole full 1 minute to read and understand the station, and then let me know when you're ready. I'm just gonna set the timer up. Whenever you're ready, let me know.
Okay. So I can start.
Okay.
Mhm. Hi, I am Dr. Rana, one of the ED registrars. May I confirm your name and level, please?
Hi, my name is Jane. I'm an F2.
Mm-hmm. Good to see you, Jane. So, what brought you here? Any concern? Yes, Jane?
Yeah, so I was seeing this kid really in ER. He's about 7 years old. He's got terminal neuroblastoma, and he's really unwell. He's got this fever. His blood pressure's on the lower side. He's breathing really fast, and there's no feeling of care documented. And I don't know what to do. Should we call PICU, or should I start just the full treatment? What do you suggest?
Mm-hmm. So, where's the patient right now? Have you taken the patient in the recess?
Well,
Y-
he's currently in recess. Yeah.
Yeah. And is there any other doctor attending to the patient?
Well, he's currently stable.
Mhm.
With the treatment that's already ongoing, we've started fluids and everything else.
Uh-huh. Can I just currently know the vitals of the patient? Because I need to just ensure
So
that he's.
he is still hypotensive, but the fluid's running. He's still febrile. We've given him paracetamol. His respiratory rate is still 34, but we're still treating him actively at the moment. Yeah.
Blood pressure is how much?
It's about 80, 60,
80, 60, and the temperature is around
39,
39. And the respiratory rate is 34, and the
34.
saturations
Saturation is about 94 on 15 liters of oxygen.
94. And that's it. Okay. And the heart rate
Heart rate's about 132.
132. And what any findings on the examination?
Um, yeah, we did a full examination. It looks like he's got a atypical pneumonia on top of the terminal neuroblastoma. It does look like
Uh,
he might be in sepsis.
okay. As currently as the vitals that you have just mentioned, can I just review the patient because I'm afraid the patient is currently hypotensive, tachycardic, and he's febrile.
I have left my registrar, the other registrar, with the kid. But I was just worried about the ceiling of care. That's what I'm worried about. I just do feel really out of my depth.
Mm-hmm. Okay. So, have you done any tests so far? What's the in on the examination? What's the GCS of the patient?
Well, the GCS is about, I would say, 12 or 13.
Okay. And any other positive examination finding? How did you get to know the diagnosis of the pneumonia with the, have you done some test? Any x-rays are done so far?
Yeah, there is a patch on the chest X-ray. His bloods have not really come back yet, but he is spiking a fever. The parents noted that he's got a lot of cough in the past few days along with the fever.
Mhm. And the patient is currently is a known case of terminal neuroblastoma since how long? Are they
About a few years.
And have there been any sort of a chemo or a radiotherapy sessions done so
It
far?
is terminal. So terminal means
Okay.
that they're not going to be treating it. Yeah.
Okay. So what was your concern was the line of the treatment in such patients, right?
No, ceiling of care. So I'm asking about the ceiling of care. Like, should we go for full escalation or should we just make them DNA CPR? Like
Mm-hmm.
that's what I'm struggling with, really. Should we just go all out, all guns blasting for this child when we know he's got terminal neuroblastoma? Or should we just really focus on comfort care? Because I have to then have a discussion with the parents about the ceiling of care, and I want help on how to do that.
Mhm. Really, I appreciate your concern, Jane, that before starting off with the entire treatment plan, you were concerned that in such cases where there is, like in this case, there has to be some sort of a changes. I really appreciate this. Have you just talked to the patient's attendants so far? What is their understanding regarding the terminal illness that the patient has?
So I haven't had a discussion with the parents myself, and I was hoping that you could be, you would be able to tell me how to approach the
Yeah,
subject. I am worried about this, really, about having the discussion with the parents.
exactly.
How do I tell the parents about the ceiling of care without sounding like I'm giving up on their son?
I'll definitely let you know. Regarding this, like as you just mentioned, that the patient is already in a terminal illness, right? And you know that there would be a guarded prognosis to any treatment that you would be giving. So
Mhm.
usually you do counsel the patient and check their level of understanding regarding the current ongoing treatment of the patient. So are you with me so far? So what do you
Yeah.
think?
Uh,
How should we be proceeding with the patient? What do you think?
Well, the child is 7, so the
Mm.
parents are supposed to decide on his behalf. He's not able to make his own decision. And also because of the following GCS, I don't think he has the capacity to understand. So the parents
Exactly.
would be the best choice to have a discussion with
Good,
as compared to the child.
good point. And what do you think as a medical practitioner will going to the maximum extent and doing everything in terms of the treatments, will this be helping the patient recover?
Well, I don't know. That's why I'm asking you. Like, what do you
Hmm.
think I should do in the
Already
situation? I'm really torn.
since the patient is already a known case of neuroblastoma in the last stages, so in such patients we do counsel the attendants regarding the sort of where we do not go to the maximum extent in treating the patient. We only give the symptomatic treatments. We do recommend that, but we do not do go to the full extent because we know it will not help them revive again. The patient is already in a terminal illness.
Yeah,
Are you
makes
getting this
sense. But
point?
how do I explain it to the parents? Like, how do I explain that I'm not going to be doing CPR, but I can't give the child antibiotic fluid? Like, how do I have that balance
For that, you
without
need
sounding, like I'm giving up on their child?
No, in that point, the counseling would be needed. And at any point, if you need my help, I'll be there to even counsel the attendants as well. And then you can see me how do I counsel the parents. But in that point, you need to make them realize that doing everything to the maximum extent will not give much benefit to the patient. At times, in certain circumstances, we let the patient remain because this is what the patients because your intervention will not help the patient. So what's the point of doing all those interventions instead of letting the patient remain in comfort would be the best choice. And then you do explain the code, which is the DNA CPR code in such patients, and then you let them decide.
Okay, makes sense. Yeah, thank you. I feel much better about this now. Um, Also, would you be able to help me with the phrasing? What kind of words do you think are more mellow and not cause or maybe offend the parents? Do you think you could like phrase it in a way that could help?
Mm-hmm. Like, for instance, first of all, you currently explain the condition of the patient, which is extremely critical, and then you will explain them what you have done so far. And then you are going to explain them that these are the treatment modalities that you would have had opted for. But for a normal patient and a patient with a terminal illness, things are different. What is best for your patient is what's your priority. And according to that, the DNA CPR or that sort of a treatment line is the best option. and then you give them the time to rethink that what is best for the patient, and then you phrase them and you give them that liberty, and they do get to understand when they see that your concern is regarding the patient, to let them remain in comfort, and yes, you have done your best so far.
Okay, okay, thank you. I
Mhm.
feel much
Uh,
more confident now. Just just to summarize, so we're not going all out for this child, obviously. We're going to just focus on comfort care, right? We are treating this as a palliative case.
yes.
Okay. So what options can we offer to keep like the patient, the child pain-free? What options can I give them?
For instance, in such cases, you mentioned them that for any sort of a symptom that the patient develops, you are going to give them the symptomatic treatment, but you will not be doing the CPR, the chest compressions, will not be taking the patient onto the intubation lines, and will not be doing any sort of an aggressive management or intervention, because this will not help the patient. The patient has a guarded prognosis in every sort of a illness that the patient develops, because the immunity is compromised, the patient has already been, and the patient is children have a small reserve, so they do not give much time before they get deteriorated. So
So as
things
a
on
medical, like a medical management plan, just for what I have to do, he is hypertensive, he is tachycardic.
absolutely.
Should we consider inotropes or not consider inotropes? What do you think?
Ideally, you should not consider the inotropes. Yes,
So I don't
you
have to like consider inotropes or inform PICU that, this patient's unstable, they're going to end up in the ICU. So no, ICU is not for them then.
You will be giving the fluids, the antibiotic, the oxygen, and sending out on the labs and everything. But onto the cardiac saving drugs, you will not be taking the patient.
So that's what I'm asking. So how far can we go? So we cannot give inotropes, but what can we give? What can we offer this child in terms of care?
Apart from the cardiac saving drugs, for instance, if the patient has, for instance, if the blood pressure is low and the heart rate is high, you are going to give the fluids. Then, if the patient is running fever, then give the antipyretics. If the patient is in pain, then give the
But we've
analgesics.
been having trouble cannulating the child. We've tried twice. I don't feel comfortable, honestly, trying again. So any other options with the fluids?
Yes. So, did you try the IO axis, the interosseous axis? Did you
Do,
try
do
that?
you do you really think we should put the child through an IO access when we're not going to go that far? Like we are being palliative, then do you think an IV access or an IO access is necessary then? It is
Uh, that your concern is absolutely right. Yes, we are keeping the patient on the treat palliative lines, but you are going to treat the patient
Mhm.
not aggressively and not on a cardiac support, but whatsoever the patient is running so far, you cannot leave the patient in distress just because you cannot get the IV. You have the other options as well. That's the IO access.
Okay. Thank you. Right, time's up. Good attempt. Well done. And I'm really sorry for putting you on the spot. I understand this was a really difficult scenario. This was a hybrid model of a case-based discussion, teaching, empathy, communication. A lot of these things were like merged into one. So how do you feel, Rida?
I am glad that you gave this station here, because when I was performing, I was just assuming that those people who appeared in this question in the London diet, what would they would have and been going through. We are lucky to have you on board and have you discussing this over here. It's much better than having this and on the day of the examination. Yes, it's very different this time. You were right. Exams are becoming difficult now.
That is what's got me worried, honestly. We have to rethink how we, think about the exam now. I know previously a lot of the people that do the courses have suggested saying, oh, you don't need knowledge. Communication, good enough. You just need to be able to confidently talk in a station and they will give you marks. You can confidently talk all you want in the station and you will screw this up. Why? Because there's some relevant information that was required. Now, why I was pressing Rida for that ceiling of care thing is, there's some protocols in NHS. When you say your patient is palliative, you do not put an IV access in. You don't try IVs. no IOs. Palliative patients, you treat them as best as you can. Okay, so once you've made them palliative, before that, ceiling of care is different. That ceiling of care for this child, if it's pneumonia, you give them IV antibiotic, you give them IV fluids, you give them everything that you do. But once you make them palliative, that is different. Palliative means comfort and care. If the patient is palliative, then you give subcutaneous fluids, not IV fluids. Okay. This is a technical information that you get when you work in the NHS or you go over the palliative care plan. The other thing is to lower the secretions. He's got pneumonia, going to be a lot of secretions, there's going to be a lot of pain. You give them hyoscine to reduce the secretions. You give them morphine by a syringe driver to help them with the pain. This is when they are palliative. That's different. Ceiling of care is different. DNA CPR is when their heart stops. So that applies. Do not resuscitate applies only when the child loses the pulse and you have to start CPR. That will not apply as long as they've got a pulse and a respiratory. Okay? So I hope I make this clear, this concept clear about palliation or palliative care, DNA CPR, and then ceiling of care. They're three different things. Now, what did this patient demand? So this is an ideal approach. So this patient was communication with teaching, ethical decision making, pediatric end of life care, DNA CPR, and treatment escalation planning. That is all in one that you had to do. Scene setting was that you had to ensure that the F2 had been debriefed, emotionally supported, because you see, I kept saying, I haven't done this before. I don't know what I'm doing. This is really difficult for me. You should have used those opportunities to either encourage me, advise me on what to do, saying things like, I'm glad you came to me for help, and I would happily support you and talk to the patient with you, or talk to the relatives, or talk to the parents with you. You don't have to do this alone. I know this is a really difficult situation to be in. Some of these sentences can be used. Acknowledge the distressing nature of a pediatric end-of-life decision. He's just a 7-year-old boy. Imagine the stress on the parents. Imagine the stress on the F2. This is a really difficult situation to be in. Then you've got your teaching framework. Assess their knowledge first. Ask the F2, what do I know so far? You did not assess my knowledge. Ask them what they understand about the child's condition and prognosis. Ask them if they've ever been involved in a DNA CPR discussions or ceiling of care. So then get objectives in. We did not get to the objectives because obviously it's a hybrid station. You kind of forget which structure to use. Let's go over how to sensitively approach end-of-life discussion with parents around DNA CPR and treatment escalation in the context of terminal illness. That is something that you can say. Then you've got your teaching content. So what do you teach? This is knowledge that you need to give to the actor. Understand that in a child with terminal cancer, focus shifts to comfort and dignity. Sepsis is likely terminal here. It's not going to be reversible, right? So because it is terminal, you're shifting the treatment to comfort and care and palliation. Intervention should be guided by the child's best interest. Ceiling of care in emergency medicine. Now, what does that mean? Highest level of intervention appropriate for this patient. Now, this patient is not for ITU. Highest level is going to be the ward, if in case this was a sepsis that was reversible. If this child had a reversible sepsis, he could end up in a ward scenario. Because his sepsis is terminal, he will not qualify even for a ward. They just need comfort and care, even at home, if possible, with proper nursing support. In this case, we can give them oxygen fluids, antibiotics, like I said, but they should not be intubated or shifted to the ICU. So ward-based care is going to be the highest level of care that you can offer them. DNA CPR is the do not resuscitate, okay? But do not resuscitate is only when you lose a pulse, okay? This does not mean you're not going to treat the patient. That is the parent's first and foremost concern, right? Are you giving up on my child? Are you not going to treat them? We are going to treat them, but if they lose their pulse, if they don't have a heartbeat, we're not going to be jumping on their chest and trying to restart their heart because it's a very traumatic and painful process for the child. And I'm sure you don't want that. Okay. Then you've got how to talk to the parents. You have to give this information to the F2. So prepare the setting, have your communication steps ready. So the spikes protocol is basically what you're getting at. Do the one shot, two shot method, chunk and check, and explain slowly and always check their understanding and offer support as much as you can. Okay. And then reinforcing the key teaching principles, summarizing basically empathy, non-clear jargon, focus on the child's comfort, importance of involving senior support and documentation, escalate if the F2 feels out of depth. So if this F2 said, I feel out of depth, you did a very right move by saying, I will do this. I will do this. I will do this with you. I will talk to the parents with you. So keep that in mind that this is a very good step to offer help to the F2. Deep understanding and summarize. So at the end of all of this, ask the F2 if they've understood, if they feel comfortable having a chat themselves, or if they feel comfortable with you around having a chat with them. Debrief and support. Again, ask how they're feeling after the discussing the case. And if it's too much, do they need to have a discussion with some seniors? Talk out their feelings, basically have a hot debrief. All right, so that is the end of this scenario. Any questions? I know this is a different thing that we've done. Any questions about all of what we've covered so far? Now we're just nearing the end of our presentation. If you have questions, just leave them in the comment box. This is what I wish I knew before my exam, that if you fail to plan, you plan to fail. Your study partner can make or break you. And once you have a seat, it's already too late to study. And before you apply for a seat, you should be 80% prepared at least. So keep all these things in mind when you're going to apply for your exam. And then just a few final words. MRCEM OSCE is just another practical exam. It is doable. You can pass it. All you need is practice with a dedicated partner. And failure is part of the process. Your success is just under progress. Don't worry about it. How can I help all of you? Well, I've been practicing with a lot of candidates. I was helping them prepare for the exam when I did not have a seat. And once I passed my exam, I was able to help them a bit more. And I have already done one course. I was able to have a few candidates. A few of them did appear in the exam. Their results not out yet, but we'll see how they did. That's all from my side. The second course registration are open. If you have any questions regarding all of what we've covered today, please feel free to ask. The forum is now open for questions. If not, we can end the session. And thank you everyone. Thank you very much for listening. Thank you, Oscar. Any questions you have about the course blueprint, about OSCE exam in general, about MRCEM or further training options, please feel free to ask. And I would also like to add, we do have a career guidance session planned for tomorrow for all of you. If you want to join, we'll be sharing the link in the Pakistan MRCEM Academy group. Currently, if you're not at the OSCE stage, we do have primary and SBA courses running with my co-directors. Dr. Rida is running a primary OSCE course and the SBA course is also ongoing. So if you are at those stages, you can check those out. If you are waiting for a seat in the OSCE, good luck. Keep applying. That's all I have for you guys. Okay, so yeah, got a fair idea about the exam. Definitely need to have. Yeah, that is true. You do need a lot of practice. I would say you need a lot of practice. The guidance you can get, yes, but you need to know where to get that guidance from. And as long as you have that sorted, all you need to do on your part is going to be practice. We do help in all ways we can, but in order for us to help you, You do have to put in the practice. That's all we ask. I want to ask the last station you discussed. It's a hybrid, right? So where would it be placed on the SLS? Very good question, Faiza. I don't know. The answer is that. The thing is, they have made all 16 stations hybrid. They don't mark them as SLOs like this now. When you get your result, they do put it in an SLO category. But if you give the exam and then you get the result sheet, you will not be able to tell which station did they put in front of which SLO. And I had the same thing. The only station I was able to actually tell, like, okay, yeah, this might be the station that they've given me the marks for, was procedures and teaching. The others was such a mix, or peds, I would say. I was able to tell that as well. But the others were such a mix that it's really difficult. What they're doing is essentially they make these hybrid stations, and then in the pie chart, they score the highest for the SLO they want to put it against. So if it's SLO1, they're going to give SLO1 component of it the highest percentage in the pie chart, but they will have the other domains. If it is teaching, for example, in this is a teaching station, essentially. If it's teaching, they will put maximum marks for teaching, but they will also give you knowledge, clinical reasoning in that with communication skills in that pie chart. It would have less percentage, but the maximum percentage would be what the SLO is going to get graded as. I hope it makes sense. It makes sense. Is the OSCE exam doable in next 2.5 months from scratch? I cleared my SBA exam in Jan date. Depends on your circumstances. So I haven't worked with you. I don't know what your baseline is. You can book in a session and I can assess your baseline and maybe give you an answer if it is relevant to you. In general, if you're asking, if it is from scratch, maybe it is possible. All you need is practice. If you're not working and you can put in the hours, if you can put in at least 10 hours of practice, you can do it. 2.5 months, 10 hours of practice, you can. Yes, anything is possible. You can even do it in less. The only thing you need is proper guidance and proper structure with, people you can actually confidently practice with. That's all you need. But if you don't have a proper structure and a community that you can practice with, then you are setting yourself up for failure. And OSCE exams are not really that cheap that I would suggest, giving an attempt and just winging it. I wouldn't recommend that, please. I hope that answers your question. Osman, was it who asked it? Yeah. How long is the upcoming course? 6 weeks. So the course is 6 weeks. We do 3 live sessions. I was essentially in my previous course, I was doing 4 days of live sessions, but I realized that a lot of you have commitment and it's very difficult to commit for 4 days. So we've shortened it down to 3 days a week with 4 days of practice sessions that you can do at your own time. So that is how it's going to be. 6 weeks, 3 days only commitment. But I would still keep saying, please join live sessions because you need practice. Like you've seen, you have to keep this two-way communication open for you to be able to pass the exam. Will it come? Yes, so this is for the September date specifically. The 6 weeks course is for September date candidates specifically. Should we prepare for OSCE while you prepare? You're already preparing for the OSCE while you're preparing for SBA. You are gathering the knowledge. So SBA lays the foundation for your exam. So if your concepts are clear, if your the structure and the communication we can work on. If you have the knowledge, the management plans, how the NHS system works, where to refer, who to refer, when to come back, safety netting, all of those things that you cover in SBA. If you do those, then you're already setting the stage up for OSCE. All the math stations, like common topics, will repeat again and again in every diet. Yeah, so this was a very common misconception, that you're going to get the same type of stations. ECG is going to be in every diet. Psychiatry is going to be. This time around, they've messed things up, really. They did not give you psych station. They did not give you an ECG station. They did not give you a chest x-ray. They did not give you a very straightforward teaching station. So anything is possible. RChem is changing their OSCE exam now. Like they were focusing on changing primary and SBA. They've now started changing the OSCE now. So your previous way of learning, okay, yeah, I know what the stations were. I'm just gonna practice them. Quick 200 station shortcuts, how I'm gonna pass the exam. That's not gonna work anymore. You do have to now actually study, prepare, have your knowledge in place along with your communication skills to be able to now pass the exam, unfortunately. I hope that answered your question, Faiza. The common topics like recess is still coming in the exam, so they haven't changed recess. Okay, thank you, everybody. If there are no more questions, we can end the session. You are very welcome, Iska. Anybody else has any queries? If not, we can stop the session here. Thank you, everybody, for listening.